Welcome back to Chiro Shift, the podcast that will change your perspective of the chiropractic profession. I'm your host, Dr. David Newton, and today I'm joined by two guests who share a passion for our profession, Dr. Rich Schoonmaker and Dr. Strat Poulson. In today's conversation, we are going to dive into the pros and cons of social media, the idea of evidence-based chiropractic, the importance of patient expectations, and a whole lot more. Unfortunately, technology was not cooperating with us on the day of recording, so we were unable to capture the first few minutes of this episode. And so we're going to jump right into the conversation where we discuss the importance of social media in today's chiropractic world. Is it a net positive, a net negative, or too hard to say? This is an amazing episode. We hope you all enjoy. All right, I know both of you guys have a background or at least a history of operating within the social media space as chiropractors, albeit maybe in two different forms or fashion. But having operated within that space and really having a chance to look at what chiropractic social media looks like from a whole, I'd love to hear your guys' perspectives on really what effect you believe social media has towards the public when it comes to chiropractic related posts. So let's start with you, Strat, because I know you've built quite a large following between all of your social media platforms. Where do you see the importance of chiropractic within social media, and do you view that as a net positive or net negative?
Yeah. So, social media is how I attract the majority of my patients, and it is how I think a lot of the profession is moving towards in just attracting new patients. You don't have to run into a chiropractor at a farmer's market or at the grocery store or at some kind of talk in order for a patient in the public to become aware of the chiropractic profession. And so because of that, I do think that social media is a net positive for the profession. Historically, we've had a pretty low utilization rate. And although the way that social media posts about chiropractic are portrayed are not always very tasteful, I do think that in general, getting the public to be more aware of the fact that chiropractic exists and could potentially help them is a net positive both for the profession and for patients. I'm not sure really how it was in the 80s when you had to do everything boots on the ground, but majority of patients, because we have a low utilization rate, were never aware of chiropractic. And so it was not unusual, I believe, 30, 40 years ago to talk to someone who has never been to the chiropractor, doesn't really know what chiropractic is, and doesn't know anyone who has been to the chiropractor. And now, at least in my experience in 2024, even when I talk to people who've never been to the chiropractor, because most people still have never been, most people at least have seen chiropractic videos, know about the existence of a chiropractor. They might be chiropractic curious, and they know someone who has gone. And so I think that's a big step forward for the profession. It's a big step to helping more people and helping more patients. The way that we portray chiropractic, though, is important, I think. And they're not always, the videos on social media about chiropractic are not always super tasteful. Sometimes patients are wearing very little clothing. There's kind of an over-sexualization of the treatment process. There's kind of this carnival-ish aspect to the way that chiropractic is presented, where the adjustments are kind of like party tricks, or the whole process is kind of sensationalized or exaggerated. And I don't think that that's a good look for the profession. I can think of a chiropractor who I think did a very good job. I don't necessarily agree with a lot of the concepts and philosophy behind Gonstead Chiropractic. But Dr. Ian, who was, I believe, an Australian chiropractor, he's recently gotten into some trouble with the Australian boards, and I don't believe he posts videos anymore. He's just gone back to regular practice. But he did a really good job. Back in the day, he inspired myself, as well as many young chiropractors to get into the profession, or kind of gave you motivation to stay in school. And what I think he did a good job of is he really showed kind of the full experience. He was the first chiropractor that I saw online that made me think chiropractors are doctors, because he showed the initial conversations and the history with the patient. He showed the examination process. He showed himself reviewing x-rays and explaining care to patients. And he showed the treatment, and he showed the after results of treatments. And some of his videos would even follow the same patient over multiple treatment visits and show from, how they were responding on the first visit to how they responded at the end of their fourth visit. And so I think there are a couple chiropractors, similar vein. A lot of them happen to be Gonstead chiropractors. So, even though I don't agree with the philosophy, I think they're doing something right, because there's another Dr. Rahim, who does a fairly good job. His content has gotten more sensational as his channels have grown and gotten bigger. But at least in the beginning and in the middle of his kind of social media career, same thing, showing lots of patient conversations, lots of the exam process. So a patient watching that is getting a really good overall context of what a visit to the chiropractor may be like. And I can see how that would help a patient feel more confident going to go visit a chiropractor for the first time and help them have a little bit less anxiety knowing how that visit might go. And there are other docs in like the rehab space who are doing a really good job explaining the way that pain works and the way that loading and exercise can help you mediate that pain, reduce that pain, and get back to the activities that you love. The problem with social media, though, is that just, for every good example, there are quite a few bad examples. There are lots of people that are out there just portraying chiropractic in a very distasteful manner. And so to me, I think on the whole, social media is a net positive for the profession, a net positive for patients for chiropractic. But there are a lot of pitfalls and problems with the way that it's presented.
I'm sure there's a lot of those points that you probably agree with, Rich, but I'd like to hear your perspective on this same topic.
Yeah, it's, right off the bat, yeah, there's quite a bit. I definitely agree there. The problem with social media overall, it's unregulated. I mean, you give anybody a voice, they can say just about whatever they want. So it's kind of what Strat was saying, is that you'll get some good, but you also unfortunately get a lot of bad. And that's not me trying to say that it's a net negative, social media and its portrayal of chiropractic. I think in that same tone is that we're kind of fighting against human nature in a way that the negative things are always going to get more attention. So what do you do about that? Unfortunately, I do not have an answer. I think that's why I guess my social media presence is just trying to provide as much evidence-based care or information as I possibly can. Maybe I'm fighting up a current with that, but I don't know. I still think it's important to do those types of things, especially when we consider where the majority of people get their health information from. It's either one, they're doctors or just doctors in general, or two, it's from the internet. And it's really unfortunate with how much, and I'm not even just including chiropractic in this statement, in general, misinformation is all over the place. I can open up my social media right now and go to my whatever it's called For You page and scroll through, and 9 times out of 10, I'm probably going to find something that's not entirely valid. Now, with that said, though, I think social media has done a good job, one, allowing chiropractors to communicate with one another. I think going back, Strat was talking about, like, historically speaking, some of these pitfalls with chiropractic having to market in person, boots on the ground, even speaking with other providers. It was difficult. Social media allows us all to connect with one another and communicate. Whether or not that communication is cordial, that's up for debate. It allows us to communicate with people who maybe have questions about chiropractic, which I think is good. Now, the one caveat to all of that, though, is it was interesting bringing up like Dr. Ian, even Dr. Rahim. So both Gonstead chiropractors, I watched both of their channels or YouTube channels. I think that was the thing back then. I know YouTube is still popular today, but like back then there was just YouTube. Instagram was not even a thing. But I still remember looking at all of their videos and thinking, oh my goodness, this is crazy. What are they doing? This is awesome. They're helping people. I think, one, it's great that it was showcasing maybe some of that patient care process, but I think we also have to recognize that even though on the surface level, when we did not know any better, before we were chiropractors, before we read research, we're watching these people on YouTube who are wearing shirt and tie, they're kind, they're empathetic, and they seem very professional and they seem to know what they're talking about. But now, years down the line, I look back at those videos and I realize some of the content, a good portion of some of those videos, are not evidence-based. And it kind of represents this idea that just because somebody sounds good doesn't mean what they're saying is good or is beneficial or is valid. It's like the bone on nerve. I know that was kind of a common point of reference in some of those videos. Like the reason you have the symptom is there's a bone pressing on a nerve. We know through research that's not a valid statement. But if you don't know any better, if you simplify it enough, it sounds good. It kind of makes sense if you don't have much education with like anatomy or physiology. You're like, yeah, that kind of makes sense as to why I feel this. But when you do know about it, you're like, that can be harmful, because that's a whole other conversation. But it's this idea that there is a lot of good that can happen with social media. But if we look at some of the other parts that are really bad, is the good outweighing that bad, or is the bad outweighing that good? It's tough to say. I think it's kind of a back and forth conversation depending on what you're actually looking at in particular.
Yeah, and I think that's something that all of us would probably agree upon, is that one negative post or one post that paints the chiropractic profession from a bad perspective probably will gain much more traction than potentially even 50 to 100 posts that might be useful and in support of the profession. That's just the way that social media works, right? The controversial stuff, the stuff that really stands out, gets a lot of engagement, tends to be highly controversial and potentially incorrect a lot of the times from an information standpoint. So I know you were starting to talk, Rich, about maybe some of the information out there that would be probably considered today as not true, or proven to be not true by what we know within the current library of research and evidence that's available to us. For the listeners that maybe are not quite as aware of what some of the more current research says, in line with what we could potentially be doing as chiropractors, could you shed some light in, maybe what those doctors in those YouTube videos were discussing as far as like bone on nerve or some of those type of stances versus what we know now and maybe what we consider more evidence-based care?
So, without getting too specific on certain things, I think a good way to summarize some of what I would consider quote unquote non-evidence based information, misinformation regarding chiropractic care. It's these oversimplistic, overgeneralized statements that kind of water down whether what may be contributing to what a patient is experiencing, or what is contributing to them feeling better or even feeling worse. So, for example, the one you just mentioned, I talked about before, was this old theory within chiropractic was that the vertebral subluxation model leading to bone on nerve, resulting in nerve interference, and the lack of expression of our nervous system. I don't need to go any deeper into that, but it's this kind of weird, confusing, abstract narrative that doesn't really make sense, again, when you know more about it. It doesn't really help explain what's happening. It doesn't make patients understand or help patients understand what's happening with their body, why they're experiencing what they're experiencing, and more importantly, probably above anything, is what to do about it. Because it also, a lot of these overly simplistic statements, they kind of take the power away from the patient and they give all of the power to the chiropractor. Because it's, say you have a bone on nerve, the way we fix that, the answer is always get adjusted. There's only one person that can do the adjustment, though, and that's the chiropractor. So if the patient has their symptoms, say low back pain, that means there's a bone on nerve. And the only way to fix that bone on the nerve is to go to the chiropractor to be adjusted. And so anytime the patient has pain, they have to go to the chiropractor. They have nothing in their tool belt to help themselves. And it's a bit demoralizing. It can be really scary to think like, there's nothing I can do about this. I'm just going to have to deal with it until I get seen. And there's a whole other things like getting an appointment, spending money, resources, things like that. Now, when it comes to what we would consider evidence-based care, there are a lot of different research publications looking at best practice guidelines. I know the one that I provided to both of you, it was, I think it was one of the Peter O'Sullivan papers, but it's like 11 best practice guidelines for conservative management of musculoskeletal care. That's a bunch of word vomit basically saying what we know is likely the most effective plan of action for people who have pain, non-emergent pain, I like to call it. So things that wouldn't mean like you need to go to the hospital or have surgery or anything like that. What do we know works best for those types of people who have pain? And by and large, for the most part, if I were to summarize that, it's primarily patient education, teaching them what's happening and what to do about it, active interventions. So think like movement-based therapy. A lot of people get that confused with exercise. It doesn't have to be exercise. This can be as simple as modifying activities of daily living, working around the pain, things along those lines. But you can kind of stratify that depending on who the patient is and what their goals are, as well as things like manual therapy. But with that said, I do want to add the caveat to the manual therapy part is that all of the best practice guidelines I have read, and in my opinion, I've read quite a few, all of them say that manual therapy can be used. And we know that manual therapy can help some people in certain ways, especially with things like pain. And when I say manual therapy, for everyone listening, that includes things like adjustments as well as stretching, trigger point therapy, cupping, acupuncture, all of those. It's kind of a broad spectrum. The primary recommendation is to use those things in addition to patient education, active interventions. And there's kind of a reason for that. And it's because, at least what I've been able to interpret, based upon kind of some different papers measuring the effects that we see from manual therapy, basically the effects that people experience, the outcomes. So say somebody comes in with low back pain and you adjust them and they feel better. So the question is, what part of them feeling better is because they were adjusted, and what part of feeling better is from other things like the context. So some of us might refer to that as the placebo, and placebo is a very broad term. A lot of times it gets a negative connotation. I'm not using it necessarily negatively here. It's just another effect. But what part of them feeling better after being adjusted is because of the adjustment, and what part of it is from other things like the context, how we talk about the adjustment, them expecting to feel better, things along those lines. And unfortunately, the majority of papers show that, I think the one paper I sent to both of you also, for manual therapy itself, for pain intensity at least, it was something like 80% of the outcomes were from other things outside the specific effects of the manual therapy. So what that kind of tells us is that while manual therapies can help people, say with pain, everything around it, the context surrounding it, likely has a more profound effect. So that's why evidence-based guidelines these days say, yeah, you can provide manual therapy. That's fine. I mean, if I were being treated by somebody, I'd probably want them to provide some type of manual therapy if I'm in person and I know they can do it, just because it makes me feel better. But the best practice guidelines say that we also need to throw these other things on because they likely have more effects, more profound effects, both, or I shouldn't say both, but in short, medium, and most of all, long-term outcomes. So again, that's not to say that we can't do manual therapy. It's just evidence-based guidelines. There's a reason they say we have to do manual therapy in addition to these other things, and it's because those other things likely have the largest effect.
And we're going to give Strat a chance to respond here in a second, because we know that Strat also takes an approach to care where he is very good at spinal manipulation. He teaches a course to students and other chiropractors so that they can become better at this skill set. So I know from your perspective, Strat, that the adjustment and manual therapy can be, and often is, an incredibly important tool that you're utilizing with your patients. How do you view evidence-based care? And within that context, how are you utilizing adjustments, spinal manipulation, within the context of maybe some of the details that Rich was just discussing?
Yeah. So this is one that I do really like to talk about. And I think that I find myself in a bit of a unique position within the profession, because I would self-describe as more of an evidence-based chiropractor. Definitely, if you're comparing the evidence-based versus the philosophically based kind of spectrum, I'm much more over here on the evidence-based side. But I get a lot of heat from evidence-based chiropractors because in my practice, I primarily just adjust. I mean, I focus on delivering what I would consider a world-class adjustment. I know that there's some argument over how much skill plays a role in that, but I believe that it does. And so because I just adjust, a lot of my evidence-based peers say, well, you're not doing active interventions, you're not doing these other things that go into evidence-based care, guideline concordant care. So how can you claim to be evidence-based when all you do is adjust? Now, I find myself also getting heat from the philosophy-based chiropractors because they love my emphasis on the adjustment and my skill in the adjustment, but they don't like the way that I explain care, the way I communicate chiropractic. So I find myself in the middle taking heat from both sides on this. To me, majority of what I think constitutes good evidence-based care centers around patient communication. And that kind of goes into what Rich was saying about the contextual effects or the total picture around the way that what you're doing is presented. And so I think when we're telling patients that they have bones out of place, that are pressing on nerves, that they have spinal degeneration, and we're giving them a very broken down machine version of what's wrong with them, that we set them up to identify with their condition instead of being like, I'm a person who has pain. They say, I'm a person with blown out discs and a degenerated spine who's never going to get better, right? And so I think the way that we communicate with patients about what's going on with them is very, very important to providing a good context around whatever treatment you're going to do. So I think you could deliver guideline concordant care. Like, let's say you do some manual therapy and you do some active rehab with the patient. Maybe you do some lifestyle and nutritional counseling, but then you take a completely mechanistic viewpoint and explanation for the patient about their blown out discs and things like this. Although you're delivering what would be guideline concordant care, it's not very evidence-based in that whole context for the patient. And you may be doing more harm than good. So you're using that placebo effect on the opposite end. You have almost like a nocebo effect to it. So to me, when I'm discussing pain and things with my patients, I tend to talk more in the terms of sensitivity or aggravation or irritation of the area. When we see findings on x-rays, they go, oh, well, I got an MRI and I've got a blown disc and C6. It's like, hey, we see this a lot in patients that don't have any pain. And we see this a lot in people who then fully recover and never have relapses of pain. And so just because you have this finding on your MRI doesn't mean that that's what's causing your pain. And a lot of those explanations and the way that we explain what we're doing and why we're doing it, I think, go into what's making something evidence-based. And especially, I think, if you were to watch, for example, me and a vitalistic chiropractor at work, like you're watching us on TV and you have the volume on mute, you're not going to see a huge difference between what me and that chiropractor are doing because we're just adjusting. But as soon as you turn the volume on and you listen to the explanations for care, you see a large difference. And this kind of leads into the idea of your guidelines for evidence-based care give you a whole variety of things that either should be done or should not be done with a particular patient. I don't personally believe that you need to do every aspect of that guideline yourself to be delivering a high-quality evidence-based care. So if we're avoiding the things that it says not to do, I don't think that we have to do every single thing it says you should do. So, for me, a patient may come in, they've got this issue going on. I explain that they're sensitive, they're irritated. The adjustment is designed to reduce muscle spasm, reduce irritation, reduce that sensitivity, and get you back to the things that you can't do right now. And so for me, I'm explaining to them what I want you to be able to do is go back to the gym and deadlift. I know you hurt yourself doing that. That's what I want you to be able to do. I don't necessarily think I need to go take them out onto the gym floor and guide them through their graded exposure back to deadlifting in order to be delivering evidence-based care. I think when you make that recommendation and you are helping them make those good choices, right? You explain to the patient, hey, the better you do on the basics, diet, exercise, getting enough sleep, the better that you're going to feel overall. Doesn't necessarily mean that you need to provide them a supplementation regimen or a dietary or nutritional plan. It doesn't necessarily mean that you as the provider need to provide them the rehab or exercise therapy or the cognitive behavioral therapy. Just because you as the provider are participating in one part doesn't mean that you're not evidence-based to me. And you can choose as a provider, okay, does this patient have severe enough or enough of a problem in this domain that they warrant referral? So do I send them to a physical therapist for guided exercise? Do I send them to a dietitian for a dietary plan? Do I send them to a cognitive behavioral therapist? Or is those aspects of their care not intense enough that they necessarily need all these different providers to fill that role? Can we give them some general advice, some general information, and then do what we focus on our job and see how they work out? That's generally the approach that I take.
Yeah, and I really appreciate you giving more insight into your approach, because I think of probably most chiropractors that follow you, as you mentioned, you maybe tend to fall somewhere in between the lines. And maybe it's not clear to everyone, really what your true aim is within care. And I think that might be misrepresented at times. But this is a really important topic to touch on, and I want to be able to dive a little bit deeper here. So I want to give Rich the opportunity to either ask questions or have some type of rebuttal response for what you just said, Strat.
Yeah, I think my primary concern with this conversation or this topic at hand. So, going back to kind of what I was saying before, we have these best practice guidelines, and part of that includes things like manual therapy. Awesome. I think what I start to get a little bit concerned with, though, is when we start reducing the amount of things that we're including within those guidelines, how far can we go before the treatments we provide no longer create the outcomes we're looking for? So, for example, I had said before that how there are some publications that say up to 88%. Before I was talking about manipulation, but in general, I think they measured like 88% of the effects we see with manual therapy are from effects other than specifically from the manual therapy. So contextual factors, things that would likely be addressed through cognitive behavioral therapy. Not saying that all chiropractors are trained in that. It's a whole separate thing. But either way, let's say even just patient education, reframing their mindset towards whatever they're experiencing. That 88% can even be giving them reassuring exercises that, hey, listen, when you bend over, it's not going to make your bulging discs worse. Things along those lines in general. How much of that can we take away from the patient care experience, from the patient's perspective, before it, one, loses its effect? And then if it loses its effect, is it really evidence-based care? I kind of think of it like the analogy, like say you're like 5 years old and it's your birthday and you have a birthday cake in front of you, but take away the frosting, take away the happy birthday, David, Strat, take away the candles, and it's just cake. It's like, how are you going to feel as a 5-year-old when you're looking at that? You're like, what is this? But then say you put all that back, you put the frosting, you put your name on, you put the candles, and it's bright, it's exciting, and you're like, whoa, yay, and it has its effect now. So all of that 88% of the outcomes we see from the non-specific effects of manual therapy are the frosting, are the decorations, are the candles, the things that really give it its robustness, its importance, its value. But when we take those away, it's kind of like, it's a cake still, but is it really having the outcome that we want for our patients? And I struggle with that a little bit because the chiropractic scope of practice is pretty large. It's pretty open. It gives them the opportunity to, or it gives chiropractors an opportunity to sit down with patients for a prolonged period of time, which is something that is desperately needed in healthcare in general, and we don't have it. It allows them the opportunity to speak with their patients about what's going on, understand their ideas, their concerns, their expectations. Why are you coming in to see me today, and how can I help you? It allows them the scope to provide manual therapies, exercise therapy, lifestyle interventions, in some states, nutritional interventions, this huge cacophony of treatments that can help these patients. So to me, I feel like we have a bit of a responsibility to provide as much as we can. And that's not me saying that we need to provide everything. I think that's unrealistic. I don't think any provider should have to provide everything. That's like me saying that I need a family physician to be able to also perform neurosurgery. That's crazy. Okay. But at the same time, because chiropractors have the ability to do all those things, I think they should try and provide as much as they can in order to maximize outcomes, but also maximize the resources that the patients are using. Like, for example, some of the demographics that struggle the most with the conditions that we see as chiropractors, low back pain, neck pain, headaches, things along those lines, typically come from lower socioeconomic demographics, lower income households. They have more responsibilities, whether it's family, job, anything like that, but they have lower income. So to me, if I want to help them the most, as much as I possibly can, I'm going to provide as much as I can in my appointment with them, rather than sending them to another therapist, a PT. Here, you're also going to go see the acupuncturist. You're going to go see the massage therapist. I'm not saying that those providers aren't useful. I think from my perspective, it's just, we still want to provide as much as we can. And I don't know how much we can consider it evidence-based care if we just continue to water it down to one or two things. Like, for example, I have a quote here from one of the papers. It was, consciously using contextual effects to enhance therapeutic outcomes is only ethical if it's offered within an evidence-based path that incorporates education and therapeutic exercises in addition to passive treatments. So the evidence-based path is only if we have those things. It's okay if we provide manual therapy. I think manual therapy can help many people for many different things. But if we want to help everybody, or I shouldn't say everybody because some people will or will not. Some people are just respond differently. But if we want to try and impact as many people as we possibly can, I think we need to be doing more than just manual therapy itself.
Feel free to respond if you'd like, Strat.
Yeah. I mean, I think I like a variety of these points. I think there's a couple of things that what you've brought up that are making me think of. And one of those is going to be the unique challenge of the way that you're delivering care. So I'm not sure if when you were in practice, if you worked primarily in an insurance model, a cash-based model, and I know it was more of a collaborative model. I think when you are in an insurance-based clinic, that you can do a really good job of kind of reducing the overall resources by providing these things yourself, like you're talking about. Or even if you're not providing them yourself, the other providers on site all take the same insurance, they all bill to the same network. The total cost to the patient is quite low, even though a variety of people are involved in that care. And I think, especially when we're talking about like the economics of this, if someone chooses to come to a cash clinic like mine, it's almost akin to seeing a specialist. Like you would consider it an out-of-network specialist or something like that. So you're expecting a higher level of specialization in the care, presumably, but you're also generally expecting a higher cost in the care. And so I run a completely cash-based clinic. I suppose I could take insurance. I would have to completely change the way my office runs to manage that. But so in my experience, it's like if I can bring someone in, perform an adjustment to help reduce their sensitivity, give them an evidence-based explanation for care and what's going on with them and give them a path forward, make some recommendations about what they can do on their own to get back to activities. Maybe I provide them a quick little exercise that they can do at home, something to help with whatever their condition is, but not structured one-on-one administered rehab. I give someone some quick dietary advice or some quick supplementation advice, but not structured one-on-one dietary planning. I think that what you end up doing is you end up touching on a lot of those guideline areas, even though we're going in depth and specializing in just one. And I'm able to deliver that at my visit, which is an $80 visit. If I was to then, take a patient in my cash clinic, using me as an example, bring them in, give them their manual therapy, they're charged $80 for that. Now we're going to go do structured one-on-one guided rehab. That's going to be somewhere between 80 to 160, probably higher dollars for that. And then I'm going to spend my time creating a dietary plan for them or a nutritional plan and monitoring that, ordering blood work, panels, stuff like that. That's all going to have an additional cost. And so I think when it comes to, there's two things there. One, I prefer to specialize in manual therapy. So I'm doing my business in a way that I enjoy, but I'm also trying to reduce the overall cost. Because if I was to try and do that all in my practice, in the cash practice, the cost to the patient is going to be exorbitant. And then the question really is doing a bit, is dipping into the other areas, but not doing them completely fully, still evidence-based. I guess we could have to define or maybe get a little bit deeper into the term evidence-based. I would argue that it is. I would argue that there's nothing wrong with specializing in your particular niche, maybe dipping your toes in other areas, but not having to go all the way into them. And for me in my clinic, that helps control costs. It helps keep things down. That way patients can still come see me, which I would consider myself more of a specialist. But what goes into that is that we're going to focus on this one particular area. We're not going to go out into these other areas. And then you can make a recommendation or a referral. I can send them to an insurance-based physical therapist that might be more cost-effective for them, or an insurance-based dietitian, CBT therapist that might be more cost-effective to them. So you have to, I think, realistically consider the financial burden of collaborative care in an insurance or non-insurance-based model. And talk about, we have an ideal patient care, right? Where they're getting everything, right? This person comes in, let's say it's maybe TriWest, we're working for the VA or something. All the providers are already paid for, the person's fully covered. Well, yeah, they can go to the physical therapist, they can go to the chiropractor, they can go to the dietitian, they can go to the psychologist, and they can have that fully fleshed out, multimodal, multi-dimensional care. but your average person just in the United States is not going to have access to that type of care. And so I guess I would just say that the setting of the clinic, your ability to collaborate, your ability to provide care in an affordable manner are all going to be kind of real world checks on the ideal of fully evidence-based guideline concordant care. That's my thought on that.
And I want to touch base on one of the points you made as far as your discussion of if you were to offer those other services and the additional cost that would then lend itself to the patient that you were seeing. And one idea that I'd like to bring up, because I know more chiropractors are beginning to operate in this manner, is that instead of charging per service, there's this idea of charging for time spent, and that the services provided maybe are decided between provider and patient within that visit. So instead of, marking down, this is the amount for the nutrition, this is the amount for the rehab, this is the amount for the manual therapy, there's more just a general charge for the provider's time. And again, this tends to happen in cash-based clinics, and pretty much only in cash-based clinics, right? So I guess my question for you, Strat, to kind of follow up with some of the ideas you have there is, obviously, we know at this point that you specialize in manual therapy, and that's where you've devoted a lot of your time into skill development. When we begin to look at some of these other ideas and potentially other ways that care could be provided, do you feel like, or do you have patients that come in and from your perspective would be better off served potentially seeing a provider that maybe operates in this way, or a different provider that's offering one of these other services that falls under the umbrella of chiropractic care? Or in your mind, is for the majority of people that are coming in, is spinal manipulation a necessary or worthwhile service for the people that are coming into your office?
Yeah. So all the time, I have patients come into my office with conditions that are going to be less responsive to manual therapy and more responsive to other interventions. So they may have like a tendinopathy or a tendonitis or something like that. Many different knee conditions and things like that. Like I could sit here and I could crack your ankle, I could crack your knee, I can crack your pelvis. Some of those things are going to biomechanically help a bit. But in my mind, it's not moving the needle and it's not what they need. And so for that patient, we basically just say, hey, I would be happy to adjust you. Adjusting these areas may help to take some stress off of those areas, but really what you need is this kind of gradual increased loading that comes through structured rehab. So I think that you'd be better served by coming over here to the next room and working with the physical therapist than you really would going under long-term care with me. I know that you came to me because you saw my videos or that you want to be here. So I'm more than happy to offer you an adjustment if you would like an adjustment today. But I don't think that you're going to be well served with long-term care or establishing a care plan underneath me that is going to be predominated by manual therapy, when in reality, what you need is to come over here and see the PT. So that happens fairly often. I don't know if I mentioned this earlier, but so I work in an office where we all split the overhead kind of 4 ways. So there is a physical therapist in the office. There is a massage therapist in the office. Physical therapist does dry needling and some other therapies as well. There's a physician, Dr. Garrett Price. He primarily does wellness-based care, lab panels, and dietary recommendations and things like that. We have some group exercise in the evening when the clinicians are not there. So we all kind of split the overhead 4 ways, run our own individual businesses. So that frees me up a lot of times to recognize someone who is not needing long-term care or a plan with me, and to send them to one of the other providers either in my office or there's a pelvic floor PT that I work with in the area who's not in the office. So I send patients over to her if they need that. So it happens fairly frequently. It is rare that you encounter, I think, someone who I believe an adjustment wouldn't help at all, right? Oftentimes for most conditions, some manual therapy helps reduce sensitivity, increase range of motion. It improves the patient's confidence and their ability to go back to their everyday activities when, for example, their knee was hurting. Now it hurts a little bit less. So it's not often that I run into someone who wouldn't be served by receiving manual therapy at all. But having manual therapy predominate the treatment plan, I think, is not appropriate for everyone. And then I send those people where they need to go.
And before I hop back over to Rich here in a second, I do want to follow up with one point that you just made. And I know some of the conditions that you just listed that from your perspective might not be best served through the practice that you have. a lot of those tended to be extremity type conditions. So for those listeners, ankle stuff, knee stuff that's not within your torso, within your spine, within your neck. Do you find then that people who are coming in with conditions related to the back or the spine, that of those people, that manual therapy tends to be maybe the best option for them on average?
I would hate to generalize and say that for people with just spinal related conditions that manual therapy is the best option on average. What I will say is that you do kind of have to deal with the patient's expectation and why they've sought you out in the first place. So it's very clear through all of my marketing that I focus on adjustments. When a patient comes in to see me, they have an expectation of what they're going to receive when they arrive, which is speaking to me about their condition, doing an exam, and then getting an adjustment that's going to help alleviate their issue. So to a certain extent, I am meeting patients where they're at, but there are patients who come in with different conditions where I think, hey, this is not going to be the best long-term solution. So, I have sometimes people who come in, they're very athletic. They hurt their low back deadlifting. And I'll say, hey, we're going to give you an adjustment. Maybe we'll give you 2 or 3 adjustments over the next week. But really what you got to do is you got to go get back on the horse, right? I think you did a little bit too much weight, a little bit too soon. Maybe you weren't fully recovered. Maybe you slept poorly the night before. You just tweaked your back, right? This is not a huge problem. This is not a huge condition. You tweaked your back. So let's give you a couple adjustments so you feel better. You're comfortable going back into the gym, and then start working back towards that on your own. And usually what I say is, as you're working back towards that on your own, if you feel like this is not working, your approach towards getting back to that is not working, come back in and we'll get you directed to someone who can help you on that path, right? Even though that's not going to be me. You don't want me coaching your deadlifts, but I've done a few, but I'm not going to coach anybody. But that's a general approach. I think with the spine and with most areas, I have a belief that the adjustment can help pretty much any of those types of musculoskeletal conditions. It's going to reduce pain. It's going to reduce sensitivity, increase range of motion, inspire confidence. It may not be the primary aspect for someone's treatment, but I'm always battling the way that I present myself as that option. So patients arrive expecting an adjustment. So if I was to just say, hey, I think you're in the wrong place, some patients are appreciative of that. And then some patients are, I appreciate that I'm in the wrong place. I'd still like to get adjusted before I leave. And then you can send me wherever I'm supposed to go. And oftentimes I will oblige. And barring any contraindications or any reason I shouldn't adjust, I will oblige, give the patient what they're wanting, what they're expecting, and then try and direct them towards what I think is going to be a more productive avenue of care. But I adjust all day, every day. And so I see the application quite widely.
Feel free to follow up with that, Rich, if you'd like.
There's a lot to unpack here. It's the idea, like, do we always give patients what they want or what they expect? I think it's funny, actually, talking about patients coming to your office and they expect you to adjust them. I don't remember the exact title of the paper. David, it's one of the papers I showcase in our SMT presentation with clinical concepts. But they actually recorded whether or not people going to the chiropractor, if they expected to be adjusted, if that affected the outcome. And turns out when people expected the adjustment to help them, they had improved outcomes. We would kind of expect that, though. That's like the placebo effect itself. But it's tough. What is the answer to the question? If a patient comes to you, they want you to do something. They want you to adjust them. They want you to do X, Y, Z. Do you do it? Because on the one hand, we have the responsibility to help the patient. But on the other hand, we have the responsibility to provide the treatment that's the most effective for them. So to Strat's point, I think he did a good job explaining, like, you're going to have patients that will or have a higher likelihood of responding positively to a manual therapy. But then there will be patients who walk in and you're like, no, this is not appropriate for you whatsoever. You have a patient come in who has uncontrolled hypertension, even though they're medicated, and they have neck pain and a headache. I don't feel like I need to explain why it's probably not appropriate to adjust their cervical spine. They probably should go see the physician that is in the same office as Strat. Now, with that said, though, I still think going back a little bit to the evidence-based stuff, Strat's kind of in a unique position with all of those different providers in his office that he can immediately refer to, which is a good thing. My ideal type of healthcare system is one that allows us to frequently refer in and out when necessary, but also make that process easier. And so it's kind of one of those things where if a patient comes to us and they have some type of need that we can't provide, I'd absolutely want to send them to somebody that can provide that for them. I can't do it. I don't know how. It's not within my scope, etc. But if they come to me and I do have that ability, yeah, I would probably try as hard as I possibly can. I think more so than anything, when it comes to adjustments in general, just going back to like I'm trying to touch on all the different points there. Like I said, a lot to unpack. Spinal pain in general, I think it's good to use types of manual therapy. Is it the best thing? I don't know. I don't think so. I think there are other things that are probably better, at least low cost, low chance of like adverse event or something like that. But that's not to say that we can't use things like manual therapy. I think some people, also to Strat's point, some people respond really, really well to manual therapy. It's kind of weird. There's not actually an explanation for it. It's like if you think of a bell curve, those outliers, they just respond exceptionally well. Other people don't respond at all. I'm sure there's probably some explanation to that, whether it is contextual factors, if there is some neurophysiological effect that's going on in those people that changes how they experience and interpret whatever happens during a manual therapy. It's tough to say. Yeah.
But you bring up a really good point there, because I think, this is maybe one of the issues in people who have experienced chiropractic care and who have existed on the outliers within that bell curve spectrum, is that you have people that will praise us from the rooftops and they'll say, my chiropractor is the greatest person I've ever met with. They helped me in a situation where no one else was able to do anything, where you have the other people on the other side that maybe got signed up into a long care plan, and at the end of 30 visits and thousands of dollars out the door, they're not any better and potentially worse. So I think this is one of those discussions we really need to have, is how do we even possibly begin to identify or understand who are the likely candidates that are going to best respond to care? And then at what point do we begin to decide if spinal manipulation is a good decision for continued treatment with somebody? And this is a challenging topic, and we're not going to have time in this conversation to go down that path. But I think it's just a good point to bring to light for the audience, is that the reality is we know that for a lot of people, spinal manipulation adjustments is probably a helpful tool. And on average, it will help people with some of the things that Strat mentioned, as far as pain reduction, increases in range of motion, things of that nature. But I think another point that we understand, and we can say so with a high degree of certainty, is that those effects also tend to be transient. So I think as we get deeper into this discussion and begin to talk further about what evidence-based or what high-quality modern chiropractic care should look like based on what we know, I think this is the discussion that we really want to bring up and continue on, is how do we make these decisions in clinic? How do we decide when we should continue adjusting somebody? How do we decide who's going to be that best candidate who we most likely believe will respond to the care that we're providing? These are the challenges that we're facing. And that's why I think discussions like this can be so productive, because we can see both ends of the spectrum. We can see that multiple people can have success through different approaches. And I think all of us here on this call can agree that our goal really is the same. We want high value patient care. We want our patients to respond well, and we want the best outcomes possible. Maybe we're taking different approaches, but to me, the fact that someone like Strat and someone like Rich is willing to hop on a call and have this discussion shows me that even though people that have different perspectives on what evidence-based or what high quality care can look like, we can have these discussions that are focused on, at the end of the day, improving the quality of care that you, the patients, are receiving. So I know we spent a lot of time on this last topic, and I kind of want to be able to move on from that, despite how important that was. And I'm sure there'll be questions that are raised. We will have a link for you guys to submit any questions to this episode. Any of the papers that have been mentioned, we will have links to those if that's something that you're interested in. But I do kind of want to move on to the next topic. And, and this maybe gets a little bit into the tail end of what we were just discussing. But without getting too far into the science and the neurology and things of that nature, I want both of you to speak to and provide an explanation for, like, what is it that you feel like spinal manipulation and adjustments are actually doing for our patients. And I want you to go beyond, for you especially, Strat, like beyond the, okay, it's going to make you feel better in the short term, it's going to make you, have better range of motion, decrease pain. When you sit down and really begin to give explanations to your patients and prior patients for you, Rich, how do you really go about talking about spinal manipulation within the context of the care plans that you're providing? I'd like the listeners to have maybe a more detailed insight into the way that we talk about these things. So we'll start with you, Strat.
Yeah. So, I do not have a master's or diploma in neurology or anything like that. So I tend to avoid very specific talks about neurology. But generally, I'll explain to patients that what the adjustment does is it has a combination effect between your actual body, so your joints and your muscles, and the way that your brain and spinal cord are interpreting stimulus. So that's your sensitivity or the way that you are processing the world around you. And generally, when I'm talking to patients, I'll say something like this, like, have you ever heard of muscle memory? And they say yes. I go, okay. You kind of have a little bit of a muscle memory type situation going on with the way that your body is moving throughout the world, right? The way that you walk, the way that you sit, the way that you're used to moving. The adjustment serves as kind of an interrupt, a pattern interrupt. And it gives us a window where your body is moving differently, you're interpreting the world differently, and your levels of pain are different. And that's typically why I explain to patients that the chiropractic in the beginning is usually a bit of a process. We usually can't, some conditions you come in, we adjust you once, your pain never comes back, and we're like, wow, that was a great case, right? But most of the time, it is more transient, like you were talking about, David, where we get this relief, but then it starts to come back. And so I explain to patients that in the beginning, we see you more frequently because we want to do more interrupts and get you back into your daily life, your daily activities with a more functional or a more less sensitive kind of overall pattern. And as you start to normalize into that new pattern, or we break that muscle memory, so to speak, you require less and less visits, less and less returns to see me because you're operating in that space of lower sensitivity, better movement, and so on for more of your daily life, and it sticks longer. And the thing I always emphasize to my patients is that my job is to get the process started. Your job is to reinforce that, right? If I come in here and I make you feel better, and then you go back to sitting for 8 hours a day, this marathon seated type situations, well, I'm not going to win, right? I'm not going to beat your 6 days a week of 8 hours a day sitting with one adjustment. And so that's where the lifestyle kind of modification factors come in, where I'm talking about, hey, let's take frequent breaks, make sure we're getting up at least every hour, getting some water, doing a quick little stretch before we sit back down. Try not to have those big marathon sessions. If we're not getting some exercise, some sunlight, getting to bed at a decent hour, drinking enough water, let's try to address some of those things. And then specifically, here's a little thing you could do. Maybe it's a dead bug, or maybe it's a hip rotation exercise or something. Here's something to put some more motion into that. Let's see how you do there. And then we follow up with them visit after visit. But in general, my explanation usually revolves around that. My job is to take you from this place where you're at and get you where you want to go by reducing your sensitivity and helping to improve your overall pattern. And I usually use muscle memory and things like that as kind of an analogy because patients get it. You're like, have you heard of muscle memory? Yes. They're able to kind of follow that and track that quite well. And I'll say my job as a chiropractor is to decide what areas need to be adjusted that are going to benefit you, and then to give you adjustments there and then let you build on the progress that we've made here in the office.
Before I let you give your response to that, Rich, you mentioned something at the tail end of that, Strat, and talking about making a clinical decision on where you feel the patient would be best suited. And I know there's controversy around this, where we have research that might suggest that we can maybe adjust anywhere and we could see positive effects within our patient responses, and that maybe it isn't as important as we thought. And I will give Rich an opportunity to talk on this as well, because I know he's very well versed in this area, but I know you have a slightly different opinion that maybe looks at things a little bit differently than some of these research papers. So I'd like to give you the opportunity to discuss why you think that adjusting specific levels on specific patients might provide better outcomes than something that's a little bit more generalized?
Yeah, so I think I don't actually know if I fully fall into the camp that you're suggesting, which is that adjusting a very specific segment is required. I don't know if I would say that. Um, I think that it is quite clear that we don't have to be super segmentally specific. I also don't know that it's entirely clear that you can be super segmentally specific. That force is going to go in, it's going to affect multiple different levels, multiple different joints, multiple different muscles. Um, I do think generally, and this is from my experience and from what I've seen, is that generally when you are adjusting at or near the symptomatic area, you get more relief from the patient or you get better results. So there's research that shows that you can get just as good results in terms of outcomes for neck pain adjusting the thoracic spine. You know, some of the argument for that is maybe it's improving the biomechanics of the thoracic spine, which is connected to the neck, which improves the neck pain. I tend to think that that's probably more neurologically mediated. There's something neurophysiological or something with the sensation system that is changing as a result of the adjustment rather than a true biomechanical change, even if there is one. Or maybe it's all of them together. But I really don't think, like, this is not a hill that I die on. I don't say, like, you need to adjust C1 only on the right. Like, I have no problem adjusting C1 or C2 or C3, getting generally specific, not exactly specific. And I've got no problem adjusting the same segment on both sides. I don't believe in bone out of place model. So there's a lot of that kind of gets baked into that I really kind of throw out. I do think that the fact that you can get these responses adjusting at different sites or the opposite side is actually a great thing because it opens up a lot of windows for us to be effective in situations where we might not have been able before. So let's say, your patient has a full spine cervical fusion, or I'm sorry, a full cervical spine fusion. So we're not going to be adjusting their neck. Well, it's great that we can then relieve neck pain by affecting the thoracic spine, which we now have access to. Or let's say that the patient's right side is the most painful side, but it's so painful that we can't get them into position or that we're not confident in our ability to deliver the adjustment there without causing some type of adverse event or reaction or making the patient feel worse. Well, we can access that general region, those general principles, by either going above or below it or going maybe to the other side. So maybe the right side of the low back is too painful to adjust. We adjust the left side in the hopes that that's going to kind of reduce some of the symptoms. So I think that where some chiropractors would look at that research and go, no, that doesn't make any sense. You need to be specific. You're not going to have these effects. I'm like, well, that's nice. That means that we have more ways to approach these same conditions. But in general, I find like if my assessment leads me to believe the sacrum needs to be adjusted, I choose to adjust the lumbar spine instead. What I tend to see in practice, and this is just my observation, that patient does not respond as well as if I chose to adjust the sacrum, which is what I kind of identified as what they were needing, if that makes sense. So in general, I found that being more specific to the region, more specific to the site of pain, and more specific to, I guess, maybe the context of the patient's symptoms does tend to relieve to better outcomes in my practice.
Yeah, and I wasn't alluding to the idea that you feel that specific segments needed to be manipulated. It was more maybe specific to sites of pain or symptomatology or areas that you've evaluated and you found potentially would benefit from the services. So I'm sure Rich has some type of follow-up to that, so I'll pass it back over to him.
Yeah, I think going back to, I think the original question was or the first question was, how might we explain an adjustment to a patient? I think by and large, for the most part now, if I had somebody ask me what exactly is an adjustment, well, it's a tool that chiropractors can use to help patients for a brief period of time with their pain and maybe potentially improve some range of motion, but it's kind of helps some patients segue into other treatments like active rehab, things along those lines. But without getting too deep into that, I think it's also important. We don't really need a lot of the neurophysiological language to explain these types of things. I mean, they've even studied how much neuroscience education is valuable to people, and it's only good to a certain degree. It's like more is not always better. Eventually, even using evidence-based information to explain something away only gets you so far. Eventually, it just makes people more confused, and they start remembering certain components of it. They forget others. It's just it becomes way too confusing. So if a chiropractor is listening to this in particular, if you're looking for a specific way to describe an adjustment, keep it simple. It doesn't need to be overly complicated. It's one tool of many that chiropractors have that can modify, augment your choice of verbiage there, change how patients are perceiving pain, as well as potentially influencing things like muscle tone, maybe, and I say maybe very carefully, range of motion, because we really don't have much research to support that. Unfortunately, if you do see changes in range of motion, it's probably because of other things. But it seems to help some people sometimes with their pain, depending on the area. Now, when it comes to specificity, no, absolutely not. We don't need to be specific with adjustments. We're not with palpation, as in when we poke people, poke and prod, different things. We're not very good at telling exactly what we're poking anyway, whether it's a spinous process or a facet joint. If we're poking L3 versus L5, it's just not that simple. Now, with that in mind, I actually do agree with Strat on the idea that I don't think that means that if somebody has neck pain that we should adjust their lumbar spine. I think that's a little impersonal. The patient's coming to you with neck pain. You're like, yeah, lay on your side. And you crunch their low back. They're like, doc, my neck hurts, not my low back. So that to me is just kind of illogical. Now, with that said, though, I think there are certain publications, research publications, that do show if somebody has neck pain, you can do an HVLA, a thoracic adjustment, so a mid-back adjustment, and some people it does help with their neck pain. So say somebody has uncontrolled hypertension again, if you can perform an adjustment to their mid-back, awesome. You don't even need to touch their neck then, and see if they have improvement in pain. Obviously, we want to start adding some other things on top of that. We're not just going to crunch your mid-back and say, bye, because that is illogical. That's also impersonal. It doesn't, encompass everything that patient probably needs. But to me, the way I think about it too is this idea. Some more prominent figures on social media say that manual therapy, especially joint adjustments, spinal adjustments, joint manipulation, they interpret the literature as being that you need to be so non-specific that you can just adjust them anywhere and it doesn't matter. It's going to have the same effect. I don't personally think that's true. Because I think of it this way. If, say, for example, somebody comes in with, I don't know, a left calf strain and you're applying trigger point therapy to their left deltoid, that's not going to have the same effect. There are segmental, again, not getting too deep into pain neurophysiology, but there are like peripheral, so things away from the center of the body. There are specific receptors in the area of complaint that are probably sensitive in a way to a stimulus, a sensation, and applying a treatment to that area could potentially help that pain a little bit more than if you were less specific. But again, it's more a regional thing as opposed to like intersegmentally. If somebody has pain around like L5, the bottommost vertebrae in their lumbar spine, it probably doesn't matter if you say you're adjusting L5 or adjusting L1. It's probably going to have the same effect. But if they say they have pain in their low back and you adjust their neck, I'm not so confident that's going to have the same effect. With all that in mind, some of that is mostly my interpretation of the research, showing that if we adjust people's mid-backs, sometimes it can help with low back pain, if we adjust their mid-back, it can help with neck pain, but there's also research that has shown that adjusting the mid-back can help with low back pain, but I haven't read anything that's convincing that extends that, like adjusting the neck helps with low back pain or adjusting the low back helps with neck pain. I think it kind of depends on a couple different things, but overall, I think treatments should be specific to a point that it at least addresses the primary needs of the patient. Beyond that, I don't think you need to be super specific.
And that's such a good point, because I would say that the majority of patients who are going to the chiropractor probably have some level of expectation in what the care will look like. And this kind of wraps around to the first point in, okay, because of Strat's marketing, most patients probably expect that they will receive that type of care, right? And to your point, Rich, very much like, is it our responsibility to always give into expectations Or is it more so that we do a 180 and that's not going to be good for you? We're going to do something else. And I think the answer to that probably almost always lies somewhere in the middle. I don't think that we can completely neglect our patients' concerns and their desires for care. But I also strongly agree that it is our duty as healthcare practitioners to also point our patients into the right direction, that from our as objective opinion as we could possibly have is going to be the best route for them to get to their destination, to their goals. So I think the challenge very much becomes, how do we navigate this space to ultimately provide the best outcomes? And I think this is where there is no clear answer right now. I think there are many paths that we can take, as you've both mentioned. Within our scope, there are many tools that we can use to provide care. And as much as people think otherwise, we're not just spinal manipulators, or that's not the only thing that's within our scope, and that we do have many options. So as we close down this podcast here, because I know this conversation could go on for hours if we wanted it to, and we want to keep this in a digestible amount of time for the listeners. But I'm going to give you each an opportunity here to kind of discuss, from where we are as a profession today, and maybe where we would like to see the profession move going forward. I know all of us here probably have things that we wish would change within the profession, at least profession status quo, to allow ourselves to grow and evolve and potentially become something that works within healthcare as much as opposed to, I think a lot of times we're seeing it as existing outside of healthcare, where this nebulous thing that really has its own bubble that it lives within. But I think we all would probably say that we do have a space, especially working with certain types of conditions. Where do you see the chiropractic profession going, or where do you hope to see the chiropractic profession go in the next 5, 10, 20 plus years? And we'll start with you, Strat.
Yeah. This is interesting. I think when I was earlier in practice, I had a little bit more of a defined kind of vision or what I would hope for. And as I got into practice and I started communicating with like other chiropractors a little bit less, and there's not like the constant voices of everyone around you in school, I just kind of really started to focus on my own thing, right? So when I think of the future, I don't tend to think often in terms of like the future of the profession. I tend to think about my own path forward, the way I'm going to expand and grow my business and the future of my life. What I would just generally hope is that, because I think the social media cat's out of the bag. I think when we get into virtual reality or augmented reality, or we're all plugged into the holodeck, that is out of the bag, right? So chiropractic is going to be on social. It's going to be on whatever the next thing is. My hope would be that we can do a decent enough job portraying ourselves as trustworthy and reasonable, and that we start bringing more people into chiropractic. Because I think, to me, what's really sad is it is not a small time investment to become a chiropractor. It is certainly not a small financial investment. And most chiropractors spend a lot of their career really struggling financially, really struggling just in the path. And so I think if we had more people coming to chiropractic, if chiropractic was more accepted, if every single post didn't have someone commenting quack or you're going to stroke somebody out underneath it, if every single post wasn't just generally a total circus, and we had more congruent messaging, that we would attract more patients, and then potentially maybe there's more medical integration. I don't think that there's anything wrong with remaining outside of traditional medicine. I also don't think that there's anything wrong with integrating. I had no problem working at the VA hospital in Tri-10, although I chose not to continue to work in an integrated type setting, although I do have a lot of providers in my practice. But I think whichever way we decide to go as a profession is fine, and even maybe having a divergent profession would be fine with me. If you have people that mostly want to stay outside medicine and people who mostly want to enter into medicine, I don't think that there's anything inherently wrong with that either. I would just like to see more people who desperately need help getting that help from a chiropractor in a meaningful way that changes their life. That's what I would like to see for the profession. So I'd just like to see some growth and I guess increased credibility.
And Rich, despite the fact that you are somewhat leaving the chiropractic profession and moving on into med school, I know you're still a proponent for high-value chiropractic care. So where do you see the chiropractic profession potentially going in the future?
Well, I'm not sure where it's going exactly. I think what I hope for, though, is that there's more regulation. I think if we want chiropractic to grow, we have to be willing to be more critical of ourselves as professionals, as healthcare providers, as patient care advocates. I think that that is more of a top down thing that is a whole other podcast that I don't have the energy to get into right now. But I think it will be a requirement if we want chiropractic to be as impactful as I personally think it could be. I think like, let's be honest. What is it? Low back pain is the number one cause. I always use this word with hesitancy, but number one cause of years lost due to disability worldwide. Low back pain costs the worldwide healthcare system such an unbelievably large amount of money, and we are so bad at treating it and managing it as a whole. And chiropractors, sans non-evidence based, and dare I say it, vitalistic narratives, chiropractic is actually armed to do something about that in an evidence-based way, in a patient-centered way, with the biopsychosocial model saving us or saving patients and the healthcare system money. And in order to do that, we need more regulation. We need more scrutiny. We need to be more critical of one another. We need to have more podcasts, maybe not podcasts, but more communication, because without any of that, it's a crapshoot. It's like we were saying at the very beginning of this. The one thing I did disagree with what Strat said was like all publicity is good publicity. I think that's what you said. Correct me if I'm wrong. To me, it's like, I don't know if it's all good publicity. It's still publicity, but it can be bad publicity. And right now, unfortunately, we're getting a lot of bad publicity for a lot of the nonsense that we just see on social media. And I think that content needs to be regulated, the way we talk about things. I think we need to kind of figure out what exactly is the identity of chiropractic. What is the point of chiropractic? And start leveraging that in favor of the patients rather than in favor of all of these other ridiculous things that don't help chiropractors nor patients at all.
And I really like that you brought forth from both of you, the levels of scrutiny and the amount of maybe bad press that is aimed towards the profession, and for good reason a lot of the time. But I think one of the primary issues that I see is that instead of engaging in productive conversation and highlighting the truly positive things that we can do as chiropractors within our profession, we have so many people that just dig their heels in and try to defend the actions versus having active conversation around how do we begin to change some of these narratives and how do we begin to make more people within the public and more people within other healthcare professions understand the scope and the aim of what it is that maybe we're discussing here today. How do we begin to move things in a direction where we are taking maybe a more evidence-based approach, or we are working within more of a contextual plan with our patients versus a defaulted plan, which I think a lot of chiropractors do operate within. No matter what the condition is, we're going to use this explanation, we're going to use this treatment, and it's going to look the same across the board. And I think that's something that has very much plagued this profession. But truly part of the aim of this podcast and having guests on like Strat and Rich here today is to further this discussion of, what can a more modern or more evolved or more informed chiropractic approach really look like, so that we can begin to fill this void that Rich just discussed, as far as things, especially like back pain, and the burden that it is placing not only on individuals, but also within the healthcare system. And I think this is a huge discussion, and I very much agree that we very much have the ability and have the scope to have a drastic effect on that. But I think that's also something that we have to earn. And maybe it is a diverging profession. Maybe it is some solution we haven't talked about yet. I think that's yet to be seen. But the idea is that hopefully through conversations like this, we create more of an education, we create positive discussion, we create maybe more unity to some capacity within individuals that are passionate about seeing that change. So before we hop into another conversation and spend another hour talking about something else, we're going to shut it down for today. But I have a feeling that at some point in the future, we will revisit some of these topics. So I want to thank Strat. I want to thank Rich. I want to thank all of you who are listening today for spending some time with us. As I mentioned before, there will be a link in the description for any questions or follow-up comments that you have to this episode, and we will make sure that those questions get to the appropriate places if they are submitted. So Strat, Rich, thank you for your time. We truly appreciate having you there, and everyone else, until next time, we'll see you then.